You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hi, everybody, and welcome to a special episode of CRST, the podcast. Today, we're going to be talking about the state of OSD. I'm Dr. Preeya Gupta, a cornea and cataract specialist here in Raleigh, North Carolina at Triangle Eye Consultants. And with me, I have my dear friend, Dr. Chris Starr, who's at Weill Cornell in New York City. Chris, welcome.
Hi, Preeya. Thank you so much. Happy to be here.
Of course. We're talking about a topic that's near and dear to our heart. And, a lot has happened in the last number of months. And just when I think there can't be more things in dry eye disease, there are. Wouldn't you say that?
Oh, yeah. I'm so delighted that that's happening because, I've sort of maintained over the years that this is an area, ocular surface disease. Really, I would argue this is a subspecialty, a new subspecialty of ophthalmology. It's complicated enough. There's enough diagnostics and research and cutting edge stuff, the robust pipeline, new FDA approvals, new diagnostics, that in order to do this at the highest level, that you don't have to dedicate your entire practice to it, but you certainly have to dedicate a big chunk of it.
No, you're right. So many years back. Chris is not that much older than me. I was about to say you've been doing this longer than me, but really, I feel like, back in the day, it was kind of like, if you were a cornea specialist or an anterior segment person, of course you dealt with dry eye. And now I think even for, if you're a cornea specialist, like this is a large subtype of ocular surface disease. And it is not something that, is easily managed and takes a lot of effort to stay on top of. And I really do feel like it's becoming its own little, niche subspecialty.
Absolutely.
Yeah, within the disease process. So, I think the goal of today is really, there's a lot of therapies that are in the pipeline. We're not going to spend a lot of time reviewing everything by way of there's a lot of therapies that are out there. But we really wanted to focus our time together on kind of talking about some of these new additions, whether they're in the pipeline or recently FDA approved. And I think, for anyone out there that manages dry eye disease, staying on top of the latest and greatest is important because we still have so many people that are just suffering. Wouldn't you say so?
100%. Yeah, this is why it's such a complex area to kind of to deal with on a day-to-day basis, because there are so many people who are suffering, and it doesn't often lead to blindness or permanent reduction in vision, but from a quality of life standpoint, it's massive, and this is leading to a lot of reduction in quality of life for a lot of our patients, a lot of practitioners too. I mean, I have dry eye myself, and it can be debilitating. So I think, trying to help these patients feel better, get on with their lives, improve their quality of life, and in a lot of instances, obviously improve their vision too, because we do know that ocular surface disease can be visually significant. In fact, we coined that term in essence with our ASCRS preoperative algorithm, distinguishing between visually significant and non-visually significant ocular surface disease. So it certainly has a visual impact, which is important and can also reduce not only work productivity, but quality of life in general for most people.
So well said. And it's true. I've seen you use an artificial tear. It's not lying, people. He does have dry eye. So I constantly feel like we need new diagnostics in dry eye disease. And there's a new aesthesiometer that is, I wouldn't say it's totally mainstream yet, but I really hope that it becomes mainstream because corneal sensitivity is such an important test in ocular surface disease, whether we're trying to identify, ideally identifying neurotrophism, which is treated very differently. How would you say, this new device is helping in your practice? It's the Brill aesthesiometer.
Yeah, I agree with you. I think the corneal nerves is the sort of not final frontier, but the next huge frontier. And we've been sort of saying this for a few years now, that sort of unlocking the mysteries of the nerves and identifying nerve abnormalities sooner in the workup, in the doctor-patient relationship will lead to just enormous benefits for both doctors and patients. I think the classic stigma of dry eye disease, oh, the doctors are like, oh, they hear a patient is coming in for dry eye and they cringe because, well, why is that? Is it because it's complicated? No, it's because it's frustrating. Because a lot of times you treat somebody for a quota, and this is an audio podcast, but if you could see me, I've got two gigantic air quotes over my head. The patients come in for quote unquote dry eye, but don't have dry eye. They get treated for dry eye and don't get better. They come back, in a few weeks, in a month, and I'm not better. And the doctor is like, wait, what? You have dry eye. I treated you for, and then this back and forth and frustration on both sides, and why a lot of sort of older people who have been doing this for a while hate dealing with these patients because of that frustration. And why is there this disconnect, this discordance between symptoms and signs? Well, often it's because of the corneal nerves, whether it's a neurotrophic situation where the corneas look terrible, they're staining, but the patients don't have symptoms, and you've treated them for dry eye, but they still look like crap, and you're like, what's going on here? Or the flip side, which is they look fine, they don't have any staining, the cornea is perfect, there's no fluorescein breakdown, and they're miserable and have significant symptoms, and that's of course neuropathic corneal pain. And what is the best way for picking all of that up sooner? Checking corneal sensation. I mean, of course, the history is important and looking for risk factors and all of that, but I think a lot of people aren't even certain what the risk factors are of neurotrophic and neuropathic pain, and maybe don't ask for it because a lot of times it's extraocular, risk factors, so it just gets missed. I'm guilty of this myself many, many times.
This program is brought to you in part by AbbVie, celebrating over 75 years focused on innovation in eye care.
So that's a long introduction to the Brill aesthesiometer, which is a non-contact point of care aesthesiometer that can take a measurement in under a minute. I've only had it for a few weeks in my clinic, and I have a great medical student who's doing a lot of this kind of work with it, and preliminary work, and adapting it and teaching my technicians and generating data. And we'll probably publish some papers on this as well, but just the early experience. And within the first day, he was able to check both eyes in under a minute. It's actually faster than what my techs do osmolarity and MMP9. So it's super quick and easy. It doesn't take a lot of time. You get a measurement on both eyes, and it's non-contact, so it doesn't disrupt the cornea. And why that is such a game changer is because in my practice prior to this, the corneal sensation was something that was only checked when I sort of thought in my head, after usually seeing the patient at least once, but often two, three, four times, in this sort of discordance. And I'm scratching my head and wondering what the hell's going on. And I write in my chart, next visit, because by the time I see them, they've usually gotten anesthesia or staining or what have you. So I'll write, big letters. Next time, let's let no drops until before the corneal sensation is checked by a doctor. And so it's this cumbersome thing, and it usually gets overlooked and what have you. So now, in the age of this new Brill aesthesiometer, I am able to have that checked right along with a questionnaire, with osmolarity, with MMP9, and with IOP, with the technician refraction, and before any drops go in. And so that is now a key screening component of my routine ocular surface exam. And I will tell you, after just a few weeks, it is illuminating beyond words. I'm sort of detecting things that I would have maybe never detected, or just missed for months and multiple visits, etc. And now we're getting this glimpse into the health of the corneal nerves right off the bat. Day one, minute one, first encounter. And I know going into this exam, even before I see the patient, kind of what their corneal sensation is. And what's great about this aesthesiometer is that not only does it give you, there's a normal range, which is right in the middle it's a 1 to 6 gradation, and a 3 is normal, and a 5 or a 6 usually is NK. They don't feel the stimulus, but a 2 or a 1 shows me that these patients have heightened sensation, that the corneal nerves are overly sensitive, i.e., they're neuropathic. So that has been the big sort of eye-opening game changer, is that we can now detect the extremes of the nerve disorders in the ocular surface. And that's to me a humongous advance in what I do on a day-to-day basis.
That's amazing. Yeah, I feel like, ocular vital signs is such a nice way to describe that, series of tests, and we just need more in the pipeline for that. A couple of, recently approved therapies, Vivi, which is, cyclosporin 1%. And then also a therapy that I've been using a lot lately is Lacrophil, which is, a cross-linked hyaluronic acid filler for the punctal system. And
I love that we're doing fillers now.
I know, right? Yeah, I was
I
just
always
gonna
wanted to
say,
get into
like,
aesthetics.
I always
Yeah.
wanted to get into the filler space. No, no, but this one actually goes away, unlike regular filler. So it's amazing. You place it, there's no foreign body like a traditional punctal plug, which honestly, like I treat a lot of dry eye. I swear to you, historically, I spend more time taking out plugs than putting in plugs because, it's like a foreign body. People get granulomas. There's just like so many reasons why people dislike plugs, like traditional plugs. And I find myself actually, since I added Lacrophil this past fall, so it's been maybe 4 or 5 months, I reach for punctal occlusion way more often when I use Lacrophil because patients tolerate it really well. There's a little learning curve to injecting it. It's just through a 25 gauge blunt cannula into the puncta. I like to get a little bit past, into the cannuliculus a little to make sure I get a nice good fill in there. But that's been something that's really exciting.
Yeah, I agree. I've had it for a few months as well. I've done a bunch of patients. I tend to I use a lot of punctal plugs in general, whether they're, sort of non-dissolvable, dissolvable, or injectable. And a lot of but of course, a lot of the patients who have punctal plugs, like you said, they need to be removed, occasionally because they feel it, because the traditional plugs are flush with the surface and they feel them and when they look nasally, or they fall out themselves and the patients come back in to get them replaced, and you sort of you go up a size and those often fall out, and or migrate internally. Sometimes we don't know where they end up. And so there is a frustration I find with punctal plugs falling out, or patients losing them. And a lot of patients love punctal plugs. I mean, it's such a simple treatment for increasing natural tears on the surface of the eye that it makes sense in patients, especially aqueous deficient patients. But I think it works in evaporative patients as well, just having more tears. If the evaporation rate is increased, but you have a lot of reservoir, it obviously is going to be beneficial to have more tears than fewer tears. But so I've been using Lacrophil or at least currently in my practice, every one of those patients who come back in because the plug either fell out or they like the plug, but it needs to be removed because of irritation. Those are the perfect candidates for Lacrophil. And I, to this day, knock on wood, have not had to flush any Lacrophils out because they had too much tearing, they had epiphora or what have you. And I agree with you. I'd like to go pretty deep and sort of fill at the canaliculus level, and sort of see a little bit of sort of backflow through the punctum to know that I filled a nice area.
And I think that's, for anyone out there, that's just a great first place to even start, is people where plugs keep falling out, or, their puncta is huge and it's not going to hold the largest size plug. And I think, it slowly becomes a preferred treatment just because it is super easy. And I think patients
Really easy. Have you had to flush one through yet?
I haven't. I haven't.
I haven't either. Yeah, but I hear it's easy. It's doable.
Absolutely.
This program is brought to you in part by Azura Ophthalmics, pioneering ophthalmic keratolytic treatments for lid margin and ocular surface diseases. We've set our sights on harnessing the unique properties of keratolytics to revolutionize the treatment of ophthalmic conditions.
Absolutely. So let's, shift gears and talk a little bit about some of the pipeline therapy. So the three kind of, what I would say impending therapies, because they are not FDA approved. So there's Reproxalab, which is a RASP inhibitor molecule. Acoltremon 0.03%, which is a TRMP agonist molecule, and then something for MGD, which is new because we've not had any topical pharmacologic therapies directly targeting the glands, and that is the selenium sulfide ointment, which is in trial. So maybe let's just take each one of these, bit by bit. So let's kick it off, Chris, with tell us a little bit about Reproxalab.
Yeah, you mentioned that it's a RASP inhibitor. What does RASP mean? It's a reactive aldehyde species. I'm not a basic scientist, so I certainly can't do a deep dive on the inflammatory cascade. But what I do know about this drug and aldehyde species is that it acts much higher in the inflammatory cascade than steroids, and certainly much higher than the immunomodulators. So when you go up, and when I think of upstream, I think of broad anti-inflammatory properties. These RAS inhibitors are up there at the top, at least in the world of ophthalmology. It's the highest we go in the anti-inflammatory cascade. And so why is that important? Well, it's a potent anti-inflammatory, but it also avoids a lot of the complications of steroids. We love steroids. We're ocular surface disease specialists, and if we could, we would probably have every single dry eye ocular surface patient on a daily steroid 2 to 4 times a day, depending on symptoms, and keep them on that for life. But we can't do that because there are substantial side effects like cataract and IOP and wound healing and infection and so on and so forth. So those are things that we use very sparingly in ophthalmology. But Reproxalap, at least in the data that I have seen, doesn't have any of those classic steroid side effects. So that's huge. And if it can have a similar anti-inflammatory effect on the ocular surface, and there is some evidence that it also sort of reduces nitric oxide and reduces oxidative stress as well. Without the side effects, then boom, we have a winner.
Absolutely. What's crazy is that this is a pathway that I think, we historically have not really paid attention to because, like most things, until we have a target for it, a molecule or something, why learn it? Because I'm like you, I'm not a big scientist. But really, reactive aldehyde species and reactive oxygen species are sort of the byproduct of any kind of stress on the ocular surface. And it's the first thing, whatever the trigger is, excessive evaporation, just a million, all those risk factors for dry eye disease. But whatever the trigger is, it creates that oxidative stress. And those reactive species, as well as those RAS molecules, really are what sort of trigger that downstream inflammation. So they're the pathway that trigger the cytokines and trigger the, that vicious cycle of inflammation. And I didn't realize it, but there's actually, lipid molecules will react to oxidative stress. And so it kind of plays a role on a variety of aspects of the ocular surface. And so this would be an inhibitor of those RAS molecules, which I think will be a really interesting pathway to target, true patients with inflammation.
Yeah, I agree. And I did see some of that data on lipids. And of course, my eyes got really wide when I saw that and the potential for that.
We don't think about the oil glands with inflammation a lot,
Yeah, exactly. And the other thing, of course, these studies were done in adverse controlled environment chambers. But like you said, the sort of insults to the ocular surface and minimizing damage from insults. And I think that the data shows pretty clearly that this can really significantly reduce the insult to the ocular surface from adverse environments like the chambers that are used in these studies. And one of the things that I really like about this is its sort of role in reducing redness. I find one of my areas of frustration as an ocular surface specialist, and maybe I'm missing something obvious, but I have a few patients in whom redness, conjunctival injection is their main problem. And admittedly, their eyes are pretty red all the time. And yes, usually they respond to steroids. You put them on a steroid taper, and usually it gets better, it goes away, or it certainly is reduced dramatically. But often when you stop the steroid, it comes back, and you're trying to control inflammation in other ways with immunomodulators and allergy meds and various ways. But I find that that chronic redness is hard to control in some patients, and I try everything. But at least in the early data that I've seen, I think it does have a role in reducing ocular surface redness. And since it is going to be a safe drop that can be used chronically, I am hoping, again, we won't know until this is released, if it is ever released, but I'm hoping that this will be my sort of silver bullet, as it were, for those patients with the chronic conj injection.
Most definitely. I mean, that's probably why so many dry eye patients even seek care, right? It's sort of a socially unacceptable side effect of ocular surface disease.
This program is brought to you in part by Brill International, focused on developing disruptive ophthalmic solutions and determined to make a significant impact on patients' lives.
So let's talk a little bit about acoltramon 0.03%. So, this is a totally different pathway as well. I love to see things in new categories, and because, as clinicians that need lots of drugs for lots of different types of patients, that who knows, maybe there could be synergy between these molecules, and of course, standalone therapy for depending on the disease severity. But acoltramon is a topical therapy, so it's an eye drop that was studied, one drop twice daily, and it is a tryptamate agonist. And so what's crazy about this, so this is actually a receptor on the surface of the eye. So these are receptors on the corneal nerves on the ocular surface, and that agonist molecule, the acoltramon, actually kind of leverages the normal basal tear secretion pathway. And that basal tear secretion, it's responsible for creating our tear production throughout the day. And what happens is that by leveraging this pathway, you get that sort of like super threshold, that large increase in tear production. And so they looked at the Schirmer's response to this molecule, and somewhere in between their pivotal trials, both trials showed about 50% of the patients actually had a 10 millimeter or greater increase in tear production, which is, if you think about 10 millimeters or more increase, I mean, that's a tremendous amount of tear production. But, it's really taking advantage of that lacrimal functional unit. So you're not getting just, reflex tears like you poked yourself in the eye or put a Q-tip in your nose. And so what it's actually doing is stimulating the goblet cells to secrete mucin, stimulating the meibomian glands to secrete oil. And then, of course, the lacrimal gland is increasing tear production.
Yeah, exactly. It's like you said, it's a cold thermoreceptor essentially. And they're on not only on the cornea, but they're also on the conjunctiva as well. And so, like you said, it modulates, and I think we're going to call this a neuromodulating drop rather than a neurostimulating device like the TruTear or the Tear via nasal spray, which does something similar via similar neural pathway. And Tear via as well can stimulate all three layers of the tear film, but via the nasal route. This will be a topical route on the ocular surface by sort of triggering those cold receptors to release that basal tear of not only aqueous but mucin and meibum, which I think is going to be groundbreaking as far as being a novel mechanism of action. I think I've never tried it, nor have you, but this idea of almost like a mentholated feeling in the clinical trials, there's a sensation. With Reproxalap, there's certainly some irritation, and there's a sensation there too. Again, I've never tried it, so I don't know. But it'll be interesting to see how patients respond and how we respond when we try these drops to this quote unquote sensation or feeling. Some will probably dislike it. Some might actually like it. A mentholated feeling on the surface of my eye, I feel like that would be something I would like to have on my eye.
Yeah, I mean, it'll be interesting to see where the patients actually land on this one, right? Because I think it is going to be, as you pointed out, a very different sensation than our typical, like, oh, this, lifitegrast burns or cyclosporin burns. It's not that typical sensation. And interestingly, both drugs do have some activity on the tryptamate receptors. So, maybe there's a commonality in terms of how patients will feel. One thing I did want to point out about the acoltramon data is that the patients noticed an improvement, as early as day one. So this is something that I'm excited about, is how, like, we typically talk in weeks and months with dry eye drugs. To be able to look at their clinical data and show an improvement at day one, I think for us as clinicians is what's going to be super exciting.
Yeah, I mean, we started at 6 months, and then when when Restasis came out, and that was
Yeah.
exciting. And then we sort of got into the 3 month clinical trials, and then in the last few years, 2 weeks, 2 to 4 weeks was something that we got really excited about and being the most rapid, fast acting. And now we're talking hours, if not, hours to a day or two. For both this one and Reproxalap. I think they're both in the clinical trials show some activity really fast, which I think is going to be again a groundbreaking, novel, game-changing kind of efficacy, rapid efficacy for sure. It's exciting.
Absolutely. It is. I know. I'm just hoping all these therapies get approved.
And the other thing about the cold thermal is, I do a lot of surface ablation surgeries, and my kind of go-to for sort of pain control in the first couple of days after PRK or advanced surface ablation is usually cold, like cold
Yeah.
chilled artificial tears, cold ice packs and Ziploc bags, just cold, and it works. And so I feel like we're onto something here with this cold receptor modulation, because it's going to help. I think maybe even beyond dry eye, we may be getting into nerve issues and corneal pain, and
Yes,
I
absolutely.
think the off-label area is going to be very interesting with both Reproxalap and Trip M8 for sure.
No
When
doubt.
if it gets FDA approved, we're going to go wild.
Yeah, we
Off
want
label use.
exactly.
This program is brought to you in part by Nordic Pharmaceuticals. You serve patients, we serve you.
And then, last but certainly not least, selenium sulfide ointment, which, this is the first topical therapy, like literally applied to the oil glands. And the science is really interesting. It has this, I don't know if you knew this, but Mybum has keratin in it. I guess I didn't think about what Mybum, I just assumed, oh, it's just oils, but no, Mybum has keratin in it. And, selenium sulfide has a history in dermatology, using it to break up, keratin that is unwanted on the skin and hair follicles and things like that. And so this is actually an ointment that is being studied. They just completed their phase 3 trial, but you apply it to the eyelid just twice per week. So it's not even a daily therapy. And it causes the disulfide bonds to lyse within the keratin within Mybum. So it helps to improve the viscosity problem that we find in patients with MGD, and also helps to kind of relieve that obstruction, but pharmacologically. So, I mean, I feel like that's huge.
Yeah. 100%. Yeah. I mean, well, like you said earlier, there is no FDA approved treatment that is disease state modifying in MGD. Mibo is a great addition for evaporative dry eye, and certainly we have tons of patients. I use it myself. I love it. It's great for for protecting the ocular surface, and it's a drop that sticks around on the ocular surface for hours rather than seconds or minutes like most other drops we put in. So it's a great addition to our armamentarium, but it doesn't necessarily do anything to the meibomian glands, at least ostensibly. There is some data that maybe it does something, but certainly we don't think of it as that. We think of it as like a super artificial tear, basically, is the way I think of it. So this is selenium sulfide, which, I kick myself for not thinking of this myself. Like, Head and Shoulders has been around forever.
So
And
simple.
the dermatology, yeah, like you said, dermatology has been using this with success for so long. So of course it makes sense to put it on the eyelid margin and break up, the keratin and the biofilm and all the stuff that obstructs the meibomian glands. It's a mechanical obstruction, not only on the lid margin surface, but also inside the glands, like you said, and the keratin that mixes with the meibum and causes the viscosity to increase. So if you can neutralize all of that stuff, you not only improve the lid margin, you improve the remove the obstruction to the flow out of the meibomian glands, but you also get into the meibomian glands and improve the architecture of the glands and the efficiency of the meibum production and reduce the viscosity of the meibum, and boom, you've got a treatment, the first of its kind treatment for the disease of MGD.
Yeah. And I think, like we've kind of alluded to in several different therapies, but the synergistic potential, right? A lot of ocular surface disease is mixed mechanism, MGD, aqueous deficiency, inflammation, so many different aspects. And so I really think the special sauce is going to be in our ability to have so many different pathways to leverage. And rather than thinking of, as we wrap up here, as I think to, the next 5 years of dry eye treatment versus the last 5 years, I feel like having tailored therapies that all work on different pathways, we will have to be smarter about kind of diagnosing dry eye disease and trying to figure out, okay, what is really happening in this patient, for us to figure out which therapy we might want to start first or concomitantly. And, hopefully we get access to these drugs. That's always the elephant in the room for our patients. But that's, this is much more of a tailored approach, I feel like, in the next 5 years, as opposed to, okay, well, here's the 3 or 4 things we have, and let's just put it on the list.
I totally agree. Yeah. I mean, it's precision medicine is where I think a lot of fields are going. And certainly the ocular surface, we're certainly heading in that direction. And the more when you said access to drugs, you're referring to insurance and coverage and all that, but also we want access to the things that have not been FDA approved yet either. So that's another access point that we want. And I love the word synergy, like you said, synergistic. And when we were talking about the Azura selenium sulfide product, well, it's going to be great if it gets approved, and it will be a tremendous for these MGD patients. But it doesn't mean I'm going to stop recommending blepharoexfoliation to mechanically remove a lot of this buildup on the lid margin. Doesn't mean I'm going to stop recommending thermal pulsation devices or IPL. It certainly doesn't mean I'm going to stop using lotilaner for Demodex blepharitis. These are all adjunctive synergistic treatments in that those combination therapies, even for ostensibly the same disease, anterior blepharitis or MGD. All of those things have a tremendous role. They all do different things. And I think that they can all work synergistically to get patients feeling better, looking better as quickly as possible. And like you said, it's always multifactorial. But in these last few years, as the diagnostics have improved and the point of care diagnostics, now the aesthesiometer and lactoferrin is another new one. There are new tests coming in, and for each of those diagnostic tools, we have new treatments now that we can sort of fine tune and tailor our regimen to sort of tackle all of the various multifaceted ocular surface disease subtypes that are inevitably present if you look for them and find them. So that's the future.
I couldn't agree with you more. Well, Chris, thanks for joining. It looks like our time is up. And once again, I want to thank everybody for listening to this special episode on the state of ocular surface disease. And be sure to tune in next time for another episode of CRST, the podcast.
For more shows like the one you just listened to, check out the podcast channel on itube.net.